this video series, we will demonstrate the components of a rheumatology shoulder exam, beginning with a brief overview of shoulder anatomy. The shoulder is composed of four joints: the sternoclavicular joint, acromioclavicular joint, glenohumeral joint, and the scapulothoracic articulation posteriorly. Relevant anterior bony structures include the sternum, the clavicle, the scapula consisting of the acromion and coracoid process, and the humerus. Key anterior muscles include the pectoralis major and minor, sternocleidomastoid, biceps brachii, and deltoid. Posteriorly, other important bony structures include the spine of the scapula and the medial and lateral scapular borders. Important posterior muscles include the trapezius, the latissimus dorsi, deltoid, beneath which lie the rotator cuff muscles consisting of the supraspinatus, infraspinatus, teres minor, and subscapularis, as well as the triceps brachii. Other important structures in the shoulder include the ligamentous joint capsules, cartilaginous labrum, and several bursae, all of which can become inflamed and damaged with rheumatologic conditions. With these anatomical structures in mind, we can begin our examination of the patient, starting with inspection. Inspection of the shoulder joint begins with the patient seated on the examination bed with both shoulders visible and free to move. It's essential to inspect the shoulder from the front, as well as the side and the back, and compare to the contralateral shoulder. As a clinician, there are 5 entities to look for on joint inspection. First, start by observing for swelling in the shoulder. Typically, swelling is seen as a fullness in the deltopectoral groove anteriorly. Next, erythema can be visualized anywhere on the shoulder and may indicate infection or inflammation. Atrophy in the surrounding muscles is typically seen as a squaring of the deltoid or a hollowing of the supraspinatus and can be present in any shoulder pathology. Next, deformities to look for may include a step deformity indicating acromioclavicular joint pathology or fracture, or a sulcus sign indicating glenohumeral joint instability. Lastly, scars or skin changes may indicate previous surgeries or other underlying conditions. With inspection complete, we next move on to palpation. To start, bony landmarks must be assessed, including the sternoclavicular joint, along the clavicle to the acromioclavicular joint. From there, one can examine the acromion and coracoid process, which includes the tendinous origin of the short head of the biceps. Next, by cupping the shoulder laterally and getting the patient to rotate their arm, the greater and lesser tuberosities of the humerus can be felt, between which runs the tendon of the long head of the biceps. Posteriorly, the spine of the scapula, as well as the medial and lateral borders of the scapula, can be palpated. Soft tissues to be palpated anteriorly include the sternocleidomastoid, the pectoralis, as well as the deltoid and the biceps muscles, and the subacromial bursa. Soft tissue palpation posteriorly includes the trapezius, as well as some of the rotator cuff muscles, the triceps, and the latissimus dorsi muscle. With palpation complete, we can next move on to range of motion. Begin by having the patient raise their arm towards the front to examine flexion of the shoulder, which should be 180 degrees, and then towards the back to test extension, which should be about 60 degrees. Next, have the patient raise their arm to the side to examine abduction, which normally is 180 degrees, and then test adduction towards the midline, which normally is 50 degrees. Next, with the patient's elbow at their side, external rotation can be assessed, typically at 90 degrees. Finally, have the patient place their hand to their abdomen or behind their back to test internal rotation, which is normally 80 degrees. If the patient's active range of motion is limited in any of these movements, make sure to test their passive range of motion as well. With range of motion complete, we next move on to special testing. Start by having the patient abduct their arm slowly. The initial 60 degrees of movement should not reproduce their pain, as no structures are impinged under the acromion. Beyond 60 degrees, the patient should report pain occurring at the lateral side of the shoulder around the tip of the acromion process. It's important to confirm that this is the same pain that they've been experiencing prior to coming into the clinic. As the patient continues to abduct their arm past 120 degrees, the patient should report that the pain dissipates. Now have the patient lower their arm in the same controlled fashion, and again the pain should reproduce between 120 and 60 degrees of abduction. and the patient may have difficulty controlling the descent of their arm. These findings yield a positive painful arc test, which in combination with other history and physical exam can be used to inform a diagnosis of subacromial impingement syndrome or rotator cuff pathology. Start by having the patient abduct their arm to 90 degrees, and then have them medially rotate their arm so that their thumb is facing down. Next, bring their arm forward 45 degrees such that they are in the scapular plane. Next, have the patient resist you as you apply a downwards force to the ulnar aspect of the patient's forearm. A positive test will yield either weakness to resistance or pain in the lateral tip of the shoulder near the acromion process. Make sure to confirm that this is the same pain that the patient has been experiencing prior to coming into the clinic. These findings in combination with other history and physical can inform a diagnosis of supraspinatus or rotator cuff pathology. Start by asking a patient to relax and let you do all the movement as this test is performed passively. Next, hold the patient's arm with one hand proximal to the elbow and one hand proximal to the wrist and passively flex their shoulder and elbow both to 90 degrees. Next, internally rotate the patient's arm. A positive test will yield pain at the tip of the patient's shoulder near the acromion process during this motion. Be sure to confirm with the patient that this pain is the same pain that they have experienced prior to coming into the clinic. These findings in combination with other history and physical exam can inform a diagnosis of subacromial impingement syndrome or rotator cuff pathology. Start by asking the patient to relax and let you do all the movement as this test is performed passively. Next, stabilize the patient's scapula with one hand and hold the patient's arm or forearm with the other hand. Internally rotate the patient's arm so that their thumb is facing down, and passively raise their arm anteriorly through full range of motion. A positive test will yield pain in the tip of the patient's shoulder near the acromion process during this motion. Be sure to confirm with the patient that this pain is the same pain that they have experienced prior to coming into the clinic. These findings in combination with other history and physical can inform a diagnosis of subacromial impingement syndrome or rotator cuff pathology. Start by asking the patient to raise their arm anteriorly to 90 degrees with their palm facing up and to hold that position. Stabilize the scapula with one hand, and with the other hand apply a downward force to the patient's forearm against their resistance. Next, repeat the same process but with the patient's arm raised to 45 degrees instead. A positive test in either position will yield pain in the anterior shoulder where the tendon of the long head of the biceps is located within the bicipital groove of the humerus. Be sure to confirm with the patient that this pain is the same pain that they've experienced prior to coming into the clinic. These findings in combination with other history and physical can inform a diagnosis of bicipital tendinitis. Start by having the patient keep their arm at their side with their elbow flexed at 90 degrees and their hand in neutral. Next, with one hand, hold the patient's forearm proximal to their wrist, and with the other hand, stabilize the patient's shoulder, ensuring to palpate over the bicipital groove of the humerus. Instruct the patient to turn their palm towards the sky while providing resistance with the hand on the patient's forearm. A positive test yields pain in the patient's shoulder in the region of the tendon of the long head of the biceps muscle. Be sure to confirm with the patient that this pain is the same pain that they've experienced prior to coming into the clinic. These findings in combination with other history and physical can inform a diagnosis of bicipital tendinitis.